Imagine you're a nurse working in a healthcare clinic. A terrified mother walks in, holding her little girl that's burning up with fever. She has no insurance and no ability to pay for medical care. You know that in the cabinet behind you is the medicine that will cure the little girl. You have a question to answer. Do you turn that mother and her child away? Or do you give them the medicine that will provide the cure? And if you give it to them, who is going to pay for it? Or imagine you're an ER physician. An uninsured man has presented in the ER with a life-threatening heart condition. He has no insurance, nor does he have the tens of thousands of dollars to pay the cardiologist, the hospital, or for the medical device required for his life-saving procedure. What choice does he have? Actually, he doesn't have one. Hopefully, he will receive the procedure, and he will probably spend the rest of his life trying to pay for it. In the meantime, the hospital will pay the bill as it struggles to stay in business. I'm Jimmy Childrey Jr. I'm from rural Georgia, and I grew up working in my father's Chevrolet dealership. 3 years after graduating from Georgia Southern, my father encouraged me to become his competitor. At 25 years old, I opened Childrey Ford in Sandersville. Now, when I was 25, that was the oldest I had ever been. I didn't realize how young I was or the risk I was taking. Childrey Ford just celebrated our 44th anniversary. As a Ford dealer, I've been active in a lot of community organizations, a lot of statewide organizations. But when I was asked to join my local nonprofit hospital board, I was reluctant. I had no experience in healthcare, but I jumped in. During those first 2 years as a board member, the problems became apparent to me. Rural communities need healthcare, but keeping their hospitals open was growing tougher every year. When I was asked to become chairman, I needed answers. I enrolled at Duke University to study healthcare management. I enrolled at the University of Cambridge to do research in nonprofit businesses. In these programs, I learned all I could about the healthcare industry and the nonprofit business world. And my focus was on rural nonprofit hospitals like ours. But only when I became CEO of our hospital did I realize the severity of the challenges we faced. Predictably, a key issue is the uninsured population, especially in nonprofit rural hospitals like ours. As CEO, I had to make hard decisions. I had to collect past due accounts. Some of these uninsured patients that I was collecting from had equity in their homes. They had college savings accounts for their children. Our decision was, would we levy on their homes? Would they spend the life savings, threaten to risk their children's future to pay us? These are not easy decisions. But the problems go far beyond affecting those without the insurance. The uninsured population is everyone's problem. So let's look at how that is, how that becomes so. Obviously, the uninsured problem pose risk to themselves. They don't have access to primary care for their wellness checks, for their preventative medicines. They don't have access to their primary care to treat chronic illnesses or acute care events. They don't have the opportunity for prescription medicines or referrals to specialists. And I just alluded to another risk, the financial risk of healthcare bills that can lead them to deteriorating credit or even bankruptcy. The risk to hospitals is obvious. As the uninsured volume grows, it can lead a hospital toward insolvency. At our hospital, when I was CEO, we collected 5 cents on each dollar of services we provided to uninsured patients. Now, have you ever thought about the uninsured patient's risk to the insured patients? Probably not. But losses from uninsured patients force hospitals to charge more to insured patients. Just like any other business, the paying customers have to pay for the services for those that don't. Shifting costs from uninsured to insured patients causes the insured patients' premiums to increase, which will eventually cause more of them to become uninsured, and it creates a vicious cycle. And finally, we all pay more tax dollars. We pay more tax dollars to subsidize our hospitals because revenues can no longer cover the expenses. So what's the solution? Let's put politics aside for a moment and let's think about how we can fix this. One idea is universal coverage, the concept of everyone having an insurance policy. I know it sounds difficult, and it is somewhat difficult, but let's take a deeper look at it. The United States is the only wealthy nation in the world that doesn't provide universal coverage for all the citizens. There are about 25 million uninsured people in the United States today. In more economically depressed regions of our country, the uninsured population can reach 20%. When I was CEO of our hospital during the Great Recession, our uninsured population was 25%. And that becomes unsustainable for the hospital. Universal insurance can be private insurance, it can be government insurance, or it can be a combination of the two. It's done in Canada, it's done in Germany, it's done in South Korea, just to name a few. And all three of those that I just mentioned have different combinations of types of insurance to achieve it. It can work. And we've been moving toward the right direction. The Affordable Care Act, the ACA, attempted to solve the uninsured problem. It mandated that all Americans have to have an insurance policy. Affordable insurance that doesn't place a burden on others. The ACA kept in place traditional private insurance. It kept in place traditional Medicaid insurance for lower income families. It kept in place Medicare insurance for the elderly. It created a marketplace that allowed individuals to buy private policies whose premiums are subsidized by the government based on the applicant's income. It also expanded Medicaid eligibility by raising the income level of low-income workers to allow them to qualify. And it was definitely a success in bringing down the uninsured population from 45 million to the current 25 million. But it hasn't solved the whole problem. Some states chose not to participate in expanding Medicaid. In those states, large percentages of the working poor remain uninsured. They have too much money for traditional Medicaid, but not enough money to qualify for the marketplace. And even for those who do have insurance, the problems persist. In order to reduce premiums today, many policies have high yearly deductibles that can reach $15,000. And some of these policies don't have a broad coverage. These patients fall into another category we refer to as the underinsured. Dr. Carmine Otis, a heart specialist in Macon, says that some insurance policies won't allow him to provide the newest medicines or treatments for his patients. He is required to use the older ones that are less effective because the newer ones cost too much. Access to affordable and timely care can also be determined by one's zip code. In the last 11 years, 12 hospitals in Georgia have closed. That leaves us with 53 counties out of 120 rural counties that don't have a hospital, creating what we refer to as healthcare deserts. Dr. Lisa Richardson, a cancer specialist and director of the CDC, says that delays in cancer diagnosis and treatment can be deadly, both for the uninsured and those living in healthcare deserts. In Georgia, our universities and state leaders are working towards solving some of our problems. We're opening new medical school campuses in Savannah, in Columbus, in Moultrie, and we're adding residencies for more doctors to practice throughout Georgia, including rural Georgia. I served on a state board that granted medical school loan forgiveness to physicians that would practice in rural Georgia. All of these efforts may work to combat the healthcare deserts, but they don't address the problems of the uninsured or even the underinsured. Large segments of our population are still at risk. The question remains, how do we achieve universal coverage? And who's going to pay for it? That's the sticking point. But let's look at what we're already spending on healthcare in this country. The U.S. spends more than $4 trillion a year on healthcare. That's an average of over $12,000 per person per year. The other wealthy nations average $6,000 per year, half of what we spend, and our number continues to grow. We'll soon reach 20% of our GDP, our total economy, on healthcare spending. Yes, achieving universal healthcare will be expensive, but our current system is expensive, and we can't afford to do nothing. Universal healthcare will make significant strides towards solving, perhaps even slowing or reversing the vicious cycle of rising healthcare costs and increasing the uninsured population. It will provide access to timely and quality care services for all people. It will lower insurance premiums for everyone. It will compensate providers for every patient they treat. And it will generate a more sustainable healthcare system, which will lower taxes for all of us. The U.S. is spending more on healthcare than any other country in the world. It's time for us to design a system that provides access to affordable and quality care for all people. A system where all patients are served at the right time, in the right place, and for all the right reasons. Let's continue the journey toward universal health care so that that nurse in the clinic can provide the best medicine for the suffering child, so that no medical professional is forced to provide less than the best care for the patients they serve, so that no one has to face financial ruin for life-saving treatment. The uninsured is everyone's problem. Let's find everyone's solution. We have the ability to design that solution. We have the money to pay for it. Will we have the compassion and the courage to make it happen? Thank you.